I'm Sarah Rudrum, and I recently completed my PhD at the Institute for Gender, Race, Sexuality, and Social Justice. So I'm going to be talking a little bit about my research and starting with some context for the study, looking at methodology, talking about findings in 4 areas, but then spending the most time with the 4th of those, which was couples HIV testing. So to situate us, the smaller map here just shows Uganda as it's situated in the Great Lakes region of East Africa. It borders with South Sudan, Kenya, Tanzania, Rwanda, and the DR Congo. And if we zoomed out a little bit to the east, there's the Indian Ocean. And if we look at the larger map, you can see with the orange arrow the area where this research was situated in Ameru district. This northern region more generally is also called Acholi land, and the people there are Acholi. I think some people are probably familiar with the decades-long war in the north of Uganda between the government's own armed forces and a group of rebels called the Lord's Resistance Army. So this conflict started in 1986 and was resolved in Uganda in 2007, although the Lord's Resistance Army is still active in a smaller scale and in neighboring countries. So it was a conflict characterized by widespread abduction, particularly of children, and as well by the internment of the majority of the population of the north into what were called IDP camps, internal displacement camps. These were euphemistically referred to by the government as protected villages, but in fact there was little protection, and there was crowding and disease and violence sort of apart from the violence of the war. So since 2007, as I said, there has been peace in the north, but there is a context of ongoing social distress sort of rooted in that conflict. There is a lack of access to basic resources and infrastructure, poverty, land disputes over land ownership as people return, and disease outbreak and the fear of disease outbreak, particularly with nodding disease and Ebola. And so the pictures here show a Meru internal displacement camp in 2007, so this would have been right before the camp was disbanded and people were making their way home to their villages, and then the same area again in 2012, which is when I was there for field work. And so this more sparsely populated picture is more how people tended to live when not in these camps. So my research question was, how is maternity care and childbirth socially organized in Ameru sub-county, a rural area recovering from conflict in northern Uganda? And I investigated this drawing on institutional ethnography. This is often called a sociology for people. And the aim is to understand social relations. The founder of this alternative sociology is Dorothy Smith. And I was lucky to take a course with Dorothy in 2010 here at UBC, alongside some nursing students as well, actually. And so IE focuses on everyday actions and experiences and is oriented to social change and social justice. So it was a good fit with my overall research aims. So I just wanted to talk about a few features of institutional ethnography that were important in this research. The first one was a reconceptualizing of institution, sort of beyond the 4 walls or the bureaucratic outline that we might associate with an institution. So the institutional context for maternity care was not only the health center or the health system, but also included non-governmental organizations, infrastructure settings, including as well as social contexts such as family. Also with work, there's a slight reorientation to move us away from thinking about work as what we do in our jobs or for pay, and towards other activities that are done intentionally with specific aims in mind and within specific constraints. And thinking about work in this way was useful for me as I sought to understand women's activities in relation to seeking care and managing their pregnancy and birth. And then texts are simply defined in IE as any graphic or textual material that can be replicated, and they're important in coordinating activities translocally. So that's between the place where the activity is carried out and some other external place where the text originates. They are exemplified in the study by a local Council 1 letter and by an antenatal card, which I'll discuss in just a minute here. So during an 8-month fieldwork period and working with an Acholi translator, I spoke with 45 childbearing women. These were women of over age 18 and who had at least one child under 2 years old. I conducted 35 individual interviews as well as 2 focus groups. And I asked about how they took care of pregnancy, their preparations for birth. They shared their birth stories and their experiences with care. So in a second stage, I spoke with health workers, and this was defined broadly to include both informal and formal health workers. And the questions here were rooted in that first stage, so the concerns brought forward by the childbearing women, as well as other points of curiosity and follow-up that I had. So on the informal side, I spoke with traditional birth attendants and with members of the village health team. So this was a group of volunteer lay people who had some responsibilities for health education and for very basic healthcare provision in their own villages. And then on the formal side, I spoke with midwives, with nursing staff, with the public health educator, and the clinical officer in charge, who was the manager at the health center. So all of those are health center staff. And then finally, I spoke with the district health officer, who was a government employee responsible for health throughout the district. And this picture here comes from the VHT handbook, but it also sort of gives a sense of what the setting was like where I was conducting interviews and focus groups. So we often also borrowed the shade of a mango tree, and someone would bring us these low benches, and that's where we would sit and talk. Because of the setting, I also drew from other methods, including resident field work and keeping field notes, and these became important to the study. So because the research was based in Amuru, this rural and remote area, I also wanted to be based there with my family. And so we lived in staff housing at the health center. The other option would be to live in a major town, Gulu, which was not too far away. But it would have meant that I didn't have the opportunity to build the relationships in the way that I did living there, as well as just learning from casual conversations and witnessing various events or tagging along on outreach and things like that. And I also kept really extensive field notes. They grew and grew. But did turn out to be really useful in that some of the more tangential things that I wrote about and worried about did become important to my understanding of the social setting and of the social organization of birth. So the first set of findings that I wanted to talk about was around transportation. And I did find that this was a complex challenge, with expense being, one dimension that was brought up again and again, but with other dimensions including bad road conditions, bad weather, dark and night, the lack of cell phone network. But really this challenge of transportation was also rooted in the fact that there weren't the number of health centers that there were supposed to be in the sub-county, and most health centers couldn't provide antenatal and delivery care. So because people had to travel beyond the nearest health center, transportation became really challenging. And so this sign reads, "Women, it's important for you to go to the health center when you're pregnant." And what I found was that women knew of this importance and tended to sort of agree with or believe in this message, especially when it came to delivery care, but there were a lot of barriers to getting there. And so here I just wanted to share a snippet of a birth story from Jackie, who lived in a remote area. And she said, "I started to feel labor pain in the evening when the sun was down and it was hard to get a boda. So one has to call a boda from Amuru to take you to the hospital. But also the phone network here is very poor, so they had to look for the network. One has to go and stand on an anthill. So by the time they had called the boda to reach here, I had already delivered because the labor started so urgently. I had to deliver with the help of a trained TBA who was around here." So you can see from her story that it's not just about expense. She was prepared to pay to get to the health center. She wanted to be there, but it wasn't possible because of these challenges that she described. So a second area was around the advice to ensure good nutrition and avoid overly arduous work. So this was the most prominent self-care advice that women knew. And they also told me that there was an irony in this advice, in that in order to eat well, one had to work hard. And this was linked to both poverty as well as to gender dynamics in their intimate relationships. So Betty told me that nutrition is good, as they tell us, but it is not easy. While the children are hungry, eggs cannot be eaten. It's impossible. So eggs were an example of like a nutritionally dense food that they'd been advised to eat, and she said, she wouldn't eat an egg while her children, couldn't and didn't have enough food. And then her neighbor, Leah, shared that some think women pretend when you tell them you're not able, so he will ask you to dig equally because the child is in the womb and not in your hand. So the context here is that everyone is, reliant on family agriculture, and there isn't necessarily a culture of rest and pregnancy. So if women hear the message, men may not. So I also wanted to talk about the mama kits, and this is one of the places where non-governmental organizations were also an institution or part of the institutional context for managing pregnancy and birth. So these were kits that were supplied by the Japanese and Uganda Red Cross for mothers, and they were administered by the village health team, who were responsible for registration, as well as by staff at the health center who actually distributed the kits after delivery. And I found that these kits were very much wanted, they were needed, but they also became a source of work for pregnant women because of these difficulties with distribution and understanding sort of who they were for, what they were for. And so this kit had basic baby supplies, including soap and cloths. The blue thing is a basin for washing. And so this, receiving the gift, as it was often called, was seen in different ways, but many people shared that it was contingent on attending 4 antenatal appointments. So 4 would have been the full complement, as well as delivering at the health facility. And so because it was contingent on doing that, it became a tool to create compliance with care. It was sort of a reward for attending all of these appointments and delivering in the hospital. And so Betty, who's the same person who told us about hunger within her family, she said that it's true that when you don't go for ANC 3 times, they don't give you the mama kit. They're right, because we women need orders. And so this view on using the kits as a tool for compliance was not always shared by everyone, but that was her view. So the mama kits also came into discourses of vulnerability and scarcity, and this was reflected when the district health officer said to me in a rhetorical question in our setting here, who is the most poor? So this was supposed to be a targeted program. There weren't enough kits for every delivery in the sub-county. But what the district health officer was pointing out here was that how can you target, how can you decide who is a vulnerable woman in this context where all families are facing poverty and lack of access to resources and so on. And so Florence in Lujoro, another remote area, took this view of the mama kits. She advocated for a vehicle, and she's clarifying for me here. Yes, that comes and gets people to take us there, but not like cloths or what, because those things will not help us. That's the help they give when they've seen how different you are. But what connects us should at least be there. So here she's saying that, as much as it's good to have cloths and soap and it's necessary, really what's going to be helpful is transportation to care. And so Helen and I with John have been working on an article with part of this quotation in the title, the help they give when they've seen how different you are. So we're hoping to see some good results on that soon. It's under review. All right. So the 4th area I wanted to discuss is couples testing during antenatal care. So this is the testing of a pregnant woman alongside her partner for HIV, and it occurs in places where HIV prevalence is relatively high. The goal here is the prevention of mother-to-child transmission, with the idea that if a pregnant woman tests negative early on, but her husband is positive, there's still some likelihood of transmission. And so the policy on this test was that it should be provider-initiated and opt-out, that people could opt out of it if they chose to. This has since changed because in 2014, the HIV Transmission and Control Act was passed. And so this meant that the test is now mandatory for both women and their husbands. It also means that healthcare providers can be required to divulge the HIV status of their patients. The Act also criminalizes HIV transmission, including the transmission from mother to child. But as I say, in 2012, that was not the policy, but nevertheless, this test seemed compulsory for both partners. So I found that it was an offer that you can't refuse. And that was similar to findings in this study I'm quoting here on HIV during antenatal care in Malawi. So this study looked at a test that was for women. It wasn't a couples test. But what the authors found was that this test that was supposed to be routine but voluntary was enacted in a way that it was compulsory, and so it became coercive. And that is similar to what I found in northern Uganda. And so this is a few ways that the compulsory approach was enacted. So the first one is the local Council 1 letter that I mentioned earlier as a text coordinating care. So this letter was required by the health center of women who were not going to bring a husband to test. The husband doesn't exist or is reluctant. The letter is written by a local Council 1 who is a political leader at the parish level. And what they tended to write was that this pregnant woman had a husband who was dead or who was in jail. And this was an exemption. So from that you can see that it seems compulsory, right? A second way was through punishments and rewards. And so the punishments also took place in villages and came from these same leaders, the local council. And they generally took the place of requiring a man who wasn't going to test to slash the grass in a shared area of the village, like in a compound or a path. And then the flip side of that was rewards. And so the rewards were given at the health center. And what would happen was on a day where a good number of men had turned up for this appointment and to test, they would be given soap, a bar of soap. And this soap came from the mama kits that I talked about earlier, and so it played into the problems of scarcity and, confusion on why it seems so unfair with the mama kits. And a third area, a really important one, was delayed care and the threat of not receiving care. And this was also sort of organized through a text, in this case the antenatal card. And so women were issued an antenatal card, like this big, with their demographic information on it and their basic health information as it pertained to pregnancy. So things like the number and outcome of previous pregnancies, as well as the HIV status. And so what happened was that when women turned up to the second appointment, which is where the test should happen, alone, they were told that bring your husband next time and you can get the card next time and see your HIV results next time. So this was the delay in receiving the card and this information as well. And the reason why this card was so important is because it was to be presented at all future antenatal appointments and especially at the time of delivery. So people worried that without this ticket, as they saw it, they would be denied care. And so in the poster here that says, responsible men go early with their wives for ANC, test together with your wife for HIV so that you prevent transmission of the virus to the unborn baby still in the womb. So in that poster, men are targeted directly, but what happened more often was that men were primarily targeted via their pregnant wife who were expected to just bring them to the appointment. And so there's information on an article where you can hear more about that. Okay, so I wanted now to talk about power dimensions in relation to the HIV test in particular, but they're also relevant to other areas of the care. So the first is institutional power at the health center and between health center staff and patients. And so there was a power imbalance that was evident in the brick and mortar structure in contrast to the patient's grassroots huts, in the uniform and education that the health workers all had, in contrast to the mostly illiterate patients who often didn't have nice clothes to wear. When I asked one of the midwives about whether women might just avoid antenatal care if they knew there was a problem with their husband, would they just try to avoid it altogether, knowing they would receive this pressure? And she said that no, they can't avoid, because they know that when they come in labor or in case of any problem, they need antenatal care. They have to have the card. All of them in the village know that without antenatal care, it is not easy to go for delivery when they are in labor. So you can see how this test, along with the card, can become a barrier to future care. And what women saw was that the health center and health workers had the power to provide care. They also had the power to withhold it from them. We've also seen the gender power that was occurring within intimate relationships and how this affected maternity care and birth. So men did tend to see pregnancy as women's exclusive domain, pregnancy and its related health care. And said this, that, quote, when you tell some men to go together with you to the hospital, he doesn't accept. You can force him, but he still will refuse. Then you get your own way of going alone to get a card. If you don't go for a checkup yourself, he doesn't care. He just sits. Women just struggle for themselves, alone. And her neighbor Faith said that there are men, when they already know their status as positive, they will not want to be supported by the hospital. Some may start to go, but nearing the hospital, they disappear. So a few women stated that there was this kind of cut and run practice where it seemed easier to go along with it and then say, oh, I just need to go do something, and then disappear. Third area of power, political power, as we've seen with the Local Council 1 letter. And this is Gloria on the letter. She said that if a mother comes without the partner, we inquire to get letters from the LC. On that, she'll find it's very difficult, and then she will go back to the husband and say, let's go to the hospital, and then they will come. So this is the sort of idealized version of what she's hoping will happen. And you can see that the LC, the local council, have been brought into this coercive approach to care, and that's how they're using their political power. And then the final area of power was the normative power to define what a relationship was. And I saw this happening at the health center through their policies. So relationships were very narrowly defined. First of all, it was assumed that there was a relationship in the case of every pregnancy. And relationships were sort of constructed as heterosexual, as married or marriage-like. And this was despite the relative prevalence of polygamy. The co-wives were not brought in any way to care by the health center. So they weren't brought into this HIV testing at all, although co-wives did often accompany their wives to their pregnant co-wives to care. And also single mothers were treated as exceptional, but were not. And so that was the final point I wanted to make on intersectional power dimensions. And overall, what I found was that a large part of the work of pregnancy for women was in confronting these power relationships, and that HIV testing was, just one of the sites where that was evidenced. That is it. Yeah, thank you for your attention. I look forward to hearing your feedback and questions. Thank you.
Thank you very much. That was really interesting.
Thanks.
I'm thinking about a couple points that I'm curious about. I was wondering, what did you find for the role of the mothers of the mothers?
Yeah.
They help to advocate for their daughters, like getting testing or telling their son-in-law, no, you can't. Or she can't be.
Great. So we're great. We're taping, so I'm going to try to repeat your question. So you're asking about what was the role of the mothers and whether they could play some kind of protective role. Marriage, the way marriage happens is patrilocal, so that most women, when they marry, won't stay with their own family. They'll go to the husband's family. So people did tend to live in these kind of multi-generational communities, like not in one house and lots of small huts, but they'd be in a circle together. And so the mother of the mother was mostly out of the picture. She might live somewhere quite far away. So mother-in-laws were quite important, and they could play either role. So in a family where the mother-in-law really felt like this was going to be a waste of money to save everything for transportation and, you know, to take a motorcycle taxi instead of walking to an appointment, you know, in that family, the mom, you know, the pregnant woman would not have support. In other families, the mother-in-law would be the person who would then, you know, accompany the pregnant woman to delivery. So it's just sort of depended on the family quite a lot. I only had one participant who had her mother there, and she said her mom was just coincidentally popping by, and she went into labor, and she was very, very happy to have her mother there. But I didn't have other people express any, you know, like regret or loss that their mother and their own siblings weren't around. Thanks.
I was just curious, you were talking about the passing that you post, like the HIV care, which criminalizes the transmission of HIV.
Yeah.
So what's the consequence? Or what has been the fallout or what's occurring after this policy has been enacted?
Yeah, so the question is about the HIV Transmission and Control Act and what the fallout has been. It's really new, so it was August 2014 that it passed. There's a lot of criticism of the bill from human rights groups and so on, and the feeling is that the mandatory test puts women in an unsafe position, as well. The rule around disclosure, you know, could potentially discourage people, individuals or organizations from testing. And then the criminalization, you know, I'm not sure if people have been, you know, tried for this yet in Uganda or not. The Transmission and Control Act is similar to a model law that was created by USAID, and these laws were replicated a lot throughout West Africa, so, you know, at the other side of the continent. And Daniel Grace has written about how that process worked, of the replication of model laws in these various West African states. But I mean, overall, the approach to HIV in the model law is very much about control and regulation, and in a way that does not seem to encourage access or openness.
A brief question. In your opinion, do you find that HIV is stigmatized the same way in Africa, where it's much more prevalent than here?
So the question is about HIV stigma and whether there's stigma. So yes, there is definitely stigma around HIV. One way, and things tend to be pretty public, you know, I'm sure some of you are from smaller communities, so these are rural and remote communities, and if there's like a workshop for HIV positive people, it will again be under a mango tree or in the backyard of the church or somewhere really central. So it can be very visible. And, you know, some of the resistance to testing is that people feel like their freedom will be constrained, especially, you know, their sexual freedom. That was, you know, what I heard about male reluctance, one thing that I heard. I'm also not clear how much people understand, you know, how the medicine works, and how much people see the value in testing for themselves. So it was quite interesting that this test, like in the poster that I showed, only focuses on prevention of transmission to the child. It doesn't really seem to suggest that there's any benefit to men themselves in knowing their status, which there is a benefit because these drugs are, now available in Uganda. They're not that expensive. So, yeah, I'm not sure how much. I think the stigma is very different place by place, but it definitely is still stigmatized.
It's just the reason why I was asking is because here I work at BC Women's Hospital, and we work with some of the women from downtown East Side that also have HIV status and things like that. They find it very discriminating. They find it difficult to find jobs because of it and things like that. So I wonder whether this new act is going to make it that much worse for the men to actually want to go get tested.
Yeah, I think the act will make it worse. I mean, I think part of the ways that HIV gets stigmatized is stigma around the modes of transmission, right? And so there's various different groups that are at risk in Uganda, but it does tend to be heterosexual women are very much at risk, which is an identity that in itself isn't stigmatized in the way that being gay is very much stigmatized and criminalized, and IV drug use is not really talked about. It's not even there's not even enough awareness for it to be stigmatized, I don't think. Does that answer? Yeah. Thanks for your question. Other questions or thoughts?
Just curious, sorry, what piqued your interest in the topic in this area?
Yeah, it evolved. So I knew going into my PhD that I definitely was going to be looking at inequities in maternity care. Didn't necessarily plan to leave the province with that, and so I did work through various iterations of topics around that. But so my partner his family is originally from Uganda. He spent a little bit of time there before this. And had some connections. So, it's a place we know. And there's also quite a connection between UBC and various universities in Uganda, mostly in Kampala. But there was this connection to Latour Hospital, who hosted me. And so it partly evolved, and then it partly happened all of a sudden when I saw some opportunity. Good question. Yeah.
You were really visible there.
Yeah.
So how did you experience this very visible position that you got? That was remote also. That many outsiders.
Yeah. So the question is about being a white woman in a black setting and sort of how I experienced that. Yeah, so I think it was an experience of being from somewhere else and being different, probably more so than being seen or interpreted as like white per se or Canadian per se. In terms of my research or my life, in terms of research, yeah. I thought a lot about sort of outsider-insider issues, and as well as the sort of ethics of, being a Canadian PhD student doing research in this setting. It was helpful for me it was necessary for me to have an Acholi translator, but she also acted in many ways as kind of an interpreter and not exactly a gatekeeper, but she did sort of help build relationships and put people at ease. So most, there were not other outsiders living in Amiru sub-county at that time, although there's tons of NGOs and tons of, Canadians and so on in Gulu, which is not very far away. But most people were not, totally unfamiliar with white workers because of the context of internment. And so the internal displacement camps were serviced by various international NGOs, sort of Red Cross, Doctors Without Borders, and so on. My son was 4 and 5 at the time of the field work, and children really reacted to his presence. He had a little bit of a hard time at school and even just sort of being out and about around town. He was a real novelty as, a child who looked different. He kind of got mobbed. He couldn't really, we would try to join like an impromptu game of soccer, but the game would like end, when he got there. So that was really tough. But we, as I said, we lived in the staff housing, and so those kids, quickly were his good buddies, and they kind of took care of him at school as well, and protected him because there was just so much curiosity that it was intrusive. But I didn't experience anything like that at all.
I remember when you were talking about the awareness of what you were was really important, right? About that.
Yeah, so I wasn't trying to fit in. That wouldn't have got very far. But I did, wear like a longer skirt always. We sat together, so if we were sitting on the ground, I would sit on the ground as well. Like sometimes people would bring 2 chairs, sort of a chair for me and a chair for my research assistant, and we weren't going to sort of sit there in a chair while the participants sat on the ground. So I also used, so I was recording with a voice recorder and with my phone as a backup recorder, and I did sort of introduce those by getting people to speak and then doing a playback, and that made I think, technology less, there was less of a question of what is that little thing, and also it was just funny, right? It's funny. People found it funny to hear their own voice played back, and sort of demystified that. I'll take your question first.
I was a little curious about the translation services.
Yeah.
Because some of the wording and the connotations just have such a strong suggestion. Like,
yeah.
I'm thinking of the person that was like, oh, women need orders, but I can, how did the translation, who did the translation?
Yeah.
How did you kind of interpret the different use of language?
So the second phase with health workers mostly happened in English, except for the focus groups with the traditional birth attendants and the village health team. And for those ones, I transcribed them myself, so they're just verbatim. I've once or twice changed words where it, for example, there was a maternal death that led to a policy change, and I know the person who spoke about that said some woman died, and I changed it to a woman died because just it sounded like he was being callous, which he wasn't. English is just used slightly differently. The first phase were all in Acholi, and so I would ask a question in English, and then my interpreter would ask the question in Acholi, and then the participant would answer in Acholi, and then my interpreter would recap the answer in English. So the first translation was on the tapes, and then the transcribed translation was done by that interpreter and by 2 other interpreters, and we sort of worked together to where they had questions, and otherwise they were mostly for like as literal as possible. That's why you see the word hospital changed to health center. The word atyat means hospital, but it also means a health center or even a pharmacy, like a private pharmacy. And so my translators tended to translate atyat as hospital, and then from context and from the actual conversation, I would know whether they meant the hospital, which was, 50 kilometers away, or the health center. Yeah. Okay. I think.
How long time did you study in Uganda?
I was there for 8 months. Yeah.
I'm just wondering, because I know very little about this area and the conflict that has gone on there. So if these are the barriers that these women are faced with in post-war, was it even more difficult for them to receive adequate care during the years and decades of unrest?
So the question is about whether the post-conflict context for getting health care was better or worse than during the conflict itself. So during the conflict, it was both better and worse, because during the times when people were at home in their villages, sort of before the IDP camps, or people who were able to stay, it was very unsafe to travel. And so the traditional birth attendants were much more active in that period. It was very hard to travel for care. But within the internal displacement camps, it might have been a case that health was worse because of crowding and so on, but health care was better because it was right there. And there were, the health center was staffed. I did hear from people that the staff were nicer post-war. Like, there were a lot of changes in how the health center ran after, as an IDP camp health center, and then after the war. But, if you were in an internal displacement camp, you would, have someone who was trained in delivery care to help you deliver.
How was it decided who got into those internal displacement camps? Or, how did that work?
Yeah, so people were forcibly displaced, and the reason behind that was that so the Lord's Resistance Army, who were this group of rebels, they had a sort of nationalist aim in that they felt they could encourage the birth of more Acholi children. This is why they kidnapped girls, and then they kidnapped boys too as fighters. And girls were forced into a marriage. So you asked about why these IDP camps and how, so the reason why the government wanted to contain the population was, partly to protect them from abduction, but also because the government also constantly saw the entire Acholi population as a potential threat, because they might voluntarily support the rebels. So sometimes people gave food to the rebels. Often their fields were raided by the rebels. And so by containing most of the Acholi people, they no longer grew food, and their children would no longer be, on a road walking to school, which is where people were getting abducted. So it was a containment strategy, sort of to prevent the LRA from growing its ranks and having access to food and so on. And it was over 90% of the population was displaced. And so, others were in cities. The towns were still existent, or else just so remote that they never got contained. Yeah.
I wondered if you considered interviewing the fathers and partners directly.
Yeah.
So why not?
The question is about whether I thought about interviewing the fathers directly. So I didn't feel that I could interview the spouses, because I felt like it would affect how much women wanted to share with me. it might create a sense that they had to be on the same page and telling the same story. That being said, I do think it would be useful to learn more from the husbands. You know, going in, I knew HIV would be important, and I knew there was relatively high prevalence and so on, but I didn't know how much that area of findings would, you know, emerge as a big one. So I think there is more work to be done with men. And, you know, there are contexts where you could interview couples together or interview both sort of parts of a couple, but I didn't really feel like this was one.
About the treatment of HIV during pregnancy.
Yeah.
The government of the Uganda is to have to supply the.
Yeah, so for the treatment during and around pregnancy, the government, this was not a government health center, this was a nonprofit health center, but they offer that, and they were offering it without a fee, and otherwise the ARVs are there's a fee. It's, you know, it's hard to say, it's relatively small, but you know, again, people don't have a lot of money. But the prevention, the mother-to-child prevention piece is offered for free, where it's offered at all. Great questions. Thank you so much. I enjoyed it. Yeah.